Okay, thank you, ma'am. So I will basically be talking about chronic liver disease in CKD patients. And while Dr. Amit has mainly shown us the association between specific etiologies of liver disease and the risk of developing kidney disease, I will try to focus on the management of specific CLD etiologies in CKD. So I'll begin with a case vignette, and after a brief introduction, I will mainly be discussing the major etiologies that we observe in CLD in patients with CKD and how to manage them, including Hep C, hepatitis B, and NAFLD. I'll discuss some of the caveats in advising and interpreting liver functions and other investigations in CKD, and how to take a decision as to when do we go for renal transplant alone, and how to take a decision when to go for a simultaneous liver kidney transplant. So we had this 59-year-old patient with end-stage renal disease who was in maintenance hemodialysis, and he was being evaluated for renal transplant. His hemoglobin was 8.1 and platelets were 1.56 lakhs. His bilirubin was 1.4. AST and ALT were 3 to 4 times of upper limit of normal. Alkaline phosphatase was around 2 times. Albumin levels were preserved. The ultrasound showed hepatomegaly along with ascites, but there was no splenomegaly and the portal vein diameter was normal. A liver stiffness measurement, which we did with FibroScan, was 14.4 kilopascal, and later it was repeated with RFA in view of ascites, and that was also 16 kilopascal. His hepatitis B surface antigen was negative. However, he was seropositive for hepatitis C antibodies, and RNA was detectable at around 4 logs. The serum ascites albumin gradient, the SAG of the ascitic fluid was 0.9. That is, it was a low SAG ascites, it was less than 1.1, and the upper GI endoscopy did not reveal any evidence of portal hypertension. So the question is that we asked ourselves was, how do we tackle his hepatitis C virus infection? And should we go ahead with a renal transplant alone in this patient, or should we consider for simultaneous liver kidney transplant? So as we know, renal dysfunction is common in patients with cirrhosis, and this figure shows the spectrum of the different types of renal involvement that can occur in patients with cirrhosis. But this will not be my discussion topic today. What I would rather be discussing is that chronic liver disease is common in chronic kidney disease patients, and that can occur because there are certain liver diseases which can involve the liver, like Dr. Amit has just discussed. There are certain systemic conditions which can involve both the liver and the kidney. And possibly most importantly, that dialysis is a very is an important risk factor for the transmission of hepatitis B and hepatitis C. So there are various primary liver diseases that can involve the liver, like IgA nephropathy is common in patients, particularly with alcoholic steatohepatitis. Hepatitis B, hepatitis C, PBC can result in renal tubular acidosis or interstitial nephritis. But the point that I really want to make is that whenever we have a patient with glomerulonephritis or nephrotic syndrome, CKD, end-stage renal disease, whatever it is very important that we rule out viral hepatitis before starting any form of immunosuppression in order to avoid potentially life-threatening flares. There are again other systemic diseases that can involve both the liver and the kidneys, like diabetes and hypertension are risk factors for NAFLD, and the diabetic nephropathy, hypertensive nephropathy are the commonest causes of end-stage renal diseases. Among the commonest causes of end-stage renal diseases, polycystic liver disease and polycystic kidney disease often go hand in hand. Sarcoidosis can cause renal stones, and with respect to the liver, it can cause liver granulomas or portal hypertension, and the other diseases that have been shown here in this table. I will not be discussing again these things also in detail. Rather, my main focus will be on the major etiologies that we encounter and how do we manage them. So coming to hepatitis C, as Dr. Amit has already discussed, that hepatitis C per se can give rise to certain kidney manifestations, of which the best described by far is mixed cryoglobulinemia, which can present with palpable purpura, arthralgias, fever, hematuria or proteinuria, or even renal impairment. And usually this is the type 2 mixed cryoglobulinemia. That is, we get the monoclonal IgM and the polyclonal IgG. Although type 3 mixed cryoglobulinemia can also be seen in hepatitis C. The association of membranous nephropathy in the absence of cryoglobulinemia remains controversial, and polyarteritis nodosa, which is more classically described in hepatitis B, can also occur in hepatitis C. However, other forms of nephropathies have also been described in hepatitis C in small reports. But patients with end-stage renal disease who are on dialysis remain a high-risk group for hepatitis C. And if we look at the prevalence of hepatitis C in this population, so this is one of the largest studies, the DOP studies, the dialysis outcomes and prevention protocols. So over there, the DOP study reported a prevalence of 13.5%. This was a multi-center study, but this is mainly Western countries, and a seroconversion of around 1.1 to 3.6 per 100 patients annually. If we look at Indian studies, then Jasuja et al. From Uttarakhand, they reported a prevalence of 27% of hepatitis C in their cohort of end-stage renal disease on maintenance hemodialysis. And the rates of seroconversion per year has been reported to be around 14.4% in a study from Delhi. And from our institute, it has been around 16.3%. And what are the risk factors for hepatitis C acquisition in these patients? It includes the duration of dialysis, breach in universal precautionary practices, hemodialysis at multiple centers, the lack of an isolated, dedicated dialysis machines, the non-availability of isolation rooms. And from our institute, we also found a unique thing of the sharing of blankets, unwashed blankets could also increase the risk, although this has not been seen in other studies. So what is very important is that since these patients are at high risk of getting hepatitis C, they should be screened for hepatitis C prior to the initiation of dialysis. And after the initiation of dialysis, it is prudent to screen them periodically using anti-HCV antibodies. And this has already been discussed in detail by Dr. Amit, that chronic hepatitis C, it increases the risk of progression of CKD, progression to end-stage renal disease. It increases the mortality risk, and persistent of hepatitis C viremia after renal transplant is also associated with an increased risk of graft loss and rejection. And most importantly, if we are able to attain a sustained virologic response, it is if we are able to cure the hepatitis C, then that results in improved clinical outcomes and survival. Shweta, baad mein karta hu. So it is of no doubt that all patients of CKD who have hepatitis C viremia, that is detectable HCV, RNA using PCR, should be treated. However, one of the important caveats in this group is that we are using anti-HCV antibodies for the screening purpose. Like I said, so we are basically screening with anti-HCV antibodies. If anti-HCV antibodies are positive, they can either indicate past infection or current ongoing infection. So the current ongoing infection is then confirmed by doing a HCV RNA and documenting the presence of HCV RNA by PCR. Now, as we know that sensitivity, that screening tests should ideally have very high sensitivities such that we do not miss out anybody with the disease. But even when using third generation ELISA tests, we find that the sensitivities have been subnormal. And in this study from our institute, indeed, the sensitivity of the third generation ELISA for anti-HCV antibodies in this population of ESRD was only a little more than 20%. And the negative predictive values have also been less than 90% in a large number of studies. Previous studies had actually shown good sensitivity and negative predictive values with even earlier generation of the ELISA tests. And the reason for that was that when the PCR sensitivity, that test that were getting used at that time, had much higher lower limit of detection as compared to the assays that we are using nowadays, which have got lower limit of detection of the virus of for only around 10 to 15 units are being detected. Therefore, if we have a high suspicion that no, this patient may be having hepatitis C, particularly if the LFTs are deranged, in those cases, even if the anti-HCV is negative and we are not finding any other etiology, it may be prudent to consider an HCV RNA in these patients, particularly if they have deranged liver functions and we are not finding any other etiology for the same. So coming to the different regimes, directly acting antiviral regimes that are available for hepatitis C. So these are all oral regimes, and they have now heralded a paradigm shift in the management of hepatitis C, in the sense that nowadays 95 to 99% of these patients, we are able to attain cure of the virus. We are able to attain a sustained virologic response with very short duration of therapy of only around 12 to 24 weeks. So these are the different regimes that are available, but among them, Elbasvir plus Grazoprevir and Glecaprevir plus Piperantesvir, which are safe in end-stage renal disease patients, are not available in India. So in India, the drugs that are available all have a Sofosbuvir backbone. And currently, we are treating hepatitis C under the National Viral Hepatitis Control Program. And over there, under the National Viral Hepatitis Control Program, the regimes that are available include Sofosbuvir Daclatasvir and Sofosbuvir Velpatasvir. So since the regimes available in India all contain Sofosbuvir as the background, we'll mainly be discussing this thing. And there has been a lot of controversy about the use of Sofosbuvir-based regimes in end-stage renal disease patients, because the primary metabolite of Sofosbuvir GS331007, this is mainly eliminated via the renal route. And there is an increase in the Sofosbuvir metabolite with changes in eGFR. And we can see that in patients with hemodialysis, both 1 hour before and 1 hour after dialysis, this metabolite is increased more than 1,000-fold. So therefore, there was a lot of concern, and early on there was the FDA did not approve the use of Sofosbuvir in this group of patients who were also largely excluded from the trials. So initially we have used low dose Sofosbuvir, that is half dose Sofosbuvir, along with full dose Declatasvir in these patients, and we demonstrated a very impressive sustained virologic response of 98%. Other investigators initially used alternate day regimes, but subsequently full dose Sofosbuvir was also used with Ledipasvir or Daclatasvir in patients with severe renal insufficiency, including those on dialysis, and significant adverse effects were not noted, and the sustained virologic responses were again impressive at above 95%. This was a phase 2 trial which used Sofosbuvir plus Velpatasvir, a multicentric phase 2 trial of around 50 to 60 patients from Europe and Australia. And they documented similar findings that there was no worsening of eGFR, there was no significant adverse effects, and there was impressive cure rates or sustained virologic responses with the use of Sofosbuvir and Velpatasvir in these patients on dialysis. One of the advantages of Sofosbuvir plus Velpatasvir is that this is a pan-genotypic regime in both patients with or without cirrhosis. And subsequently, this is some Indian data from our institute, wherein again we have demonstrated the same in a larger cohort of patients, that Sofosbuvir and Velpatasvir is safe and effective. And similar things have also been demonstrated in subsequent meta-analysis. So in November 2020, FDA permitted the use of Sofosbuvir-based regimes in patients with eGFR less than 30, and also in those patients on dialysis. Obviously, caution with ribavirin has to be practiced. So the basic point is that now these patients of end-stage renal disease who are on dialysis with hepatitis C infection can be treated in a similar fashion as patients without kidney disease using similar regimes. And we also have data about the safety and efficacy of Sofosbuvir-based regimes in the renal transplant setting. So to summarize, if we are going to treat hepatitis C virus in the end-stage renal disease setting or in the post-transplant setting in India as per NBHCP, the manner of treatment would be the same as in those patients without CKD. So it's very simple. If the patients do not have prior treatment exposure to hepatitis C antivirals, then we see whether the patient has cirrhosis or not. If the patient does not have cirrhosis, then he is treated with Sofosbuvir and Daclatasvir for 12 weeks. If he has got compensated cirrhosis, then the treatment is Sofosbuvir plus Velpatasvir for 12 weeks. And in case of decompensated cirrhosis, usually we use Sofosbuvir plus Velpatasvir plus ribavirin for 12 weeks, but because ribavirin is unlikely to be tolerated in patients of end-stage renal disease, Sofosbuvir plus Velpatasvir is for 24 weeks is the usual option that is used in these patients. However, patients who have previously failed treatment with NS5A inhibitors, others, daclatasvir, velpatasvir, ledipasvir, the asvirs, other NS5A inhibitors. Patients who have previously failed treatment with NS5A inhibitors will still remain a difficult to treat group in the Indian setting. Why? Because ideally these patients needed treatment with a drug called voxilaprevir, which is not available in India. So in India, we are currently treating them with sofosbuvir plus velpatasvir plus ribavirin for 24 weeks. And as we have just discussed, ribavirin cannot be used, is going to be very poorly tolerated in patients of end-stage renal disease. Therefore, these patients can well actually be taken up for renal transplant, and in the after renal transplant, they can then be taken up for treatment with directly acting antivirals. So another difficult point is, how do we differentiate treatment failure from reinfection in patients who are on maintenance hemodialysis? In the sense that after the documentation of hepatitis C viremia, we initiate the patients on treatment, treat them for 12 weeks. After 12 weeks after the end of treatment, we recheck the hepatitis C virus RNA levels. At that time, if the virus is undetectable, then we say that a sustained virologic response has been attained. However, who is to guarantee that the patient did not simply get reinfected during this time? It wasn't a treatment failure, but he simply got reinfected during this time. This actually remains a vexing issue. And we have shown that in patients who are deemed to have reinfection, high rates of sustained virologic response can be attained by simply retreating with sofosbuvir plus velpatasvir. How did we define HCV reinfection? Basically, these were patients with hepatitis C virus who had attained a documented sustained virologic response. However, they had high risk practices, like they were either IV drug abusers or they were on maintenance hemodialysis, and therefore they were considered to have high risk of getting a reinfection. And on subsequent follow-up, they were once again detected to have viremia. These patients were defined as HCV reinfection. And when they were treated with sofosbuvir plus velpatasvir for 12 weeks, again, the cure SVR12 was attained in 97.4% patients. So coming to the second major etiology of chronic liver disease in CKD, that is hepatitis B virus. And again, Dr. Amit has already discussed in detail about the various renal diseases that can occur in hepatitis B virus. Usually these things are more common in areas where hepatitis B is endemic, where the disease is acquired perinatally or in childhood. Membranous nephropathy has a strongest association, and to a certain extent we can differentiate membranous nephropathy due to hepatitis B from primary membranous nephropathy using the PLA2R antibodies or using immune staining for PLA2R on the biopsies. However, there have been certain reports from China that PLA2R antibodies may be present in a substantial proportion of patients with HBV related membranous glomerulopathy also. MPGN, polyarteritis nodosa, etc., various other glomerulopathies have also been described with hepatitis B, as has been discussed in detail by Dr. Amit. Now, in patients with HBV-associated kidney disease, practically always these patients are treated with antivirals. If immunosuppression is going to be used, they must always be under the cover of antivirals to avoid the risk of flares. And without antivirals, immunosuppression is unlikely to be effective in these patients. What about the risk of hepatitis B in dialysis patients? Obviously, again, these patients are at high risk of hepatitis B virus. So in the multicentric global DOP study, the prevalence was 0 to 7% with an incidence rate of 0.4 to 1.2 patients per 100 patients in a year. And from the Asia Pacific region, again, the prevalence rates have been reported to be 1.3 to 14.6%, with the higher prevalences having been reported from the Taiwanese and the Korean cohorts. And in India, in a study by Mittal from Delhi, the prevalence was around 10%. There have been several risk factors which have been well identified for that increase the risk of HBV infection in dialysis units. This includes the presence of dialyzing of hepatitis B positive patients in the same dialysis unit where seronegative patients are also being dialyzed. The lack of the provision of dedicated hemodialysis machines for these patients. lower than 50% prevalence of vaccination of hepatitis B vaccination among patients on dialysis in the unit, and failure to adhere to universal precautions and other measures to prevent bloodborne infections. So all patients before the initiation of dialysis, they should be tested for hepatitis B, and usually we test them with hepatitis B surface antigen. And if the hepatitis B surface antigen is positive, we check for the HBe antigen, anti-HBe, and the hepatitis B viral DNA. However, in this cohort, it is also important to check for the anti-HBC antibodies. Why? This is to detect occult hepatitis B. What is occult hepatitis B? Occult hepatitis B means HBsAg surface antigen is absent. However, the DNA is present in the liver with or without being present in the blood. Now, why is this occult hepatitis B important to identify in patients of end-stage renal disease, in patients of CKD and end-stage renal disease? Number one, because it can be transmitted. Therefore, these patients should ideally be dialyzed, particularly if the DNA is detectable in units or using machines that are reserved for the seropositive patients. And if these patients need immunosuppression, whether it be for the treatment of the renal disease or whether it be post-transplant immunosuppression, then they need to be put on antivirals. Definitely, if the DNA is detectable. Even if the DNA is undetectable and we're using strong immunosuppressive agents like rituximab, then again, they definitely need to be put on antivirals. If the patients are HBsAg negative, then they must be vaccinated. But we should remember that the efficacy of vaccination in patients of CKD and particularly on dialysis is lower than that in the general population. So vaccination efficacy is more than 90% in the general population, but in end-stage renal disease patients, it is only around 50%. However, we can increase that efficacy rate to around 70% by using double dose of the vaccine. That is, we use 40 microgram of Recombavax or Engerix-P. And as per the product label in EASLD patients, it is recommended that for Recombavax, the 016, the standard schedule to be used, but for Engerix-P, we use a 0126 schedule of vaccination. This is according to the product label. And periodic screening with hepatitis B surface antigen should obviously also be carried out, so that we can detect hepatitis B early enough. So the HBV treatment candidacy according to international guidelines, I will not be discussing this in detail because this is very complicated and different guidelines use different cutoffs for HBV DNA depending upon whether the patient is E antigen positive or E antigen negative. But basically, if we look at all these guidelines, then they base their decision of initiating antivirals on whether HBe antigen is positive or negative, whether the ALT values are elevated, what is the level of the hepatitis B DNA level, and some estimation of fibrosis, usually non-invasively, and if there is confusion, then using biopsy. This is what all the AASLD, the EASL, the Asia Pacific Association, all of them advocate. However, WHO had suggested certain changes, and that has now been incorporated into NVHCP, where to simplify the management and simplify the treatment decisions such that they can be incorporated even in non-specialist centers. We have now done away with HBe antigen testing in the national program. So in the national program, the treatment decisions are only being taken on ALT levels, the DNA levels, and the non-invasive assessment of fibrosis. With the important caveat being that since HBe antigen testing is not being done prior to the initiation of antivirals, antiviral hepatitis B antivirals is now going to be essentially lifelong without the availability of baseline HBe antigen. So in a nutshell, if we summarize the NVHCP things, then we are stratifying the severity of fibrosis according to APRI, FIB-4 or FibroScan if available. APRI and FIB-4 are certain non-invasive scores using commonly available blood parameters that we use to stage the severity of fibrosis. So the APRI or the AST platelet ratio index, this includes the AST and the platelet count, and the FIB-4, this includes the patient's age, AST and ALT. So if on the basis of this non-invasive assessment of fibrosis, if we feel the patient is cirrhosis, then all the patients are advocated for treatment by NVHCP, irrespective of DNA or ALT levels. If there is significant fibrosis, the patients are being treated if the DNA is more than 2000, irrespective of the ALT levels. And if there is no significant fibrosis, then patients will be treated if DNA is more than 2000 and ALT is also elevated. So the fundamental change is that the HBE antigen testing is being done away with respect to chronic liver disease patients. The main thing that has now come in is the availability of tenofovir alafenamide. Instead of previously, we were using TDF or tenofovir disoproxil fumarate. So tenofovir alafenamide is the active drug. And since this is the active drug, we are having to give a lower concentrations, 25 mg. Therefore, the systemic exposures are becoming lesser, and therefore there is less, detriment to the kidney and indeed also on bone mineral density. So this is actually a real world study which documented that when we switch over from tenofovir disoproxil fumarate to TAF or tenofovir alafenamide, the virologic response is maintained, the ALT normalization is maintained, and ALT goes further down. And more importantly, there is an arrest of the renal function decline with tenofovir alafenamide. From a practical point of view, the major advantage of tenofovir alafenamide is that it does not require any dose modification in patients who have an eGFR or more than 15 ml or in patients who are on dialysis. Now, in this group, the other drug that we were commonly using in EASLD patients was entecavir, which obviously required a dose modification. So in patients with eGFR 30 to 50, we're using entecavir 0.5 mg every 48 hours. Entecavir 0.5 mg every 72 hours if the eGFR was between 10 to 30. And in patients on dialysis, entecavir was given once every week. However, now we have evidence which suggests that even with the use of entecavir, the risk of progression of CKD stage more than 1 is higher in patients with entecavir as opposed to tenofovir alafenamide. So tenofovir alafenamide is now being preferred in patients with chronic kidney disease. However, if unavailable or there are cost predictions, then entecavir can also be used. Now coming to non-alcoholic fatty liver disease, again, Dr. Amit has discussed this in detail. We know that NAFLD has now grown up to be, catapulted into one of the commonest causes of chronic liver disease worldwide. And the metabolic comorbidities are the main risk factors of NAFLD, and diabetes, hypertension, which are also so common in our CKD population. But the point that I want to emphasize is that NAFLD as of now is a diagnosis of exclusion. So the establishment of the diagnosis of NAFLD requires the demonstration of steatosis, usually by ultrasound or using the CAP parameter of FibroScan or sometimes other imaging techniques or rarely on biopsy. Along with that, we have to rule out significant alcohol intake. By Indian definitions, we have defined significant alcohol intake as more than 2 units or more than 20 grams of alcohol intake per day, irrespective of gender. This is more strict than the Western guidelines, which allow up to 21 units in a week for males and up to 14 units in a week for females. So we have to rule out significant alcohol intake, but we also have to rule out other causes of steatosis and raised transaminases. And in this aspect, we definitely have to rule out chronic viral hepatitis, particularly hepatitis C, because remember, HCV genotype 3 is a very important cause of steatosis. And there are various links between NAFLD and CKD. This has already been discussed by Dr. Amit in detail, and I will not be going into the details of this. And again, NAFLD has been independently associated with CKD. But importantly, in this meta-analysis, they have shown that even after we adjust for diabetes, because we know that diabetes is a risk factor for NAFLD, diabetes is a risk factor for CKD. So, but even after we adjust for diabetes, even then NAFLD continues to remain independently associated with CKD. And as the stage of NAFLD increases, the eGFR continues to decline. There's a progressive decrease in eGFR as the stage of NAFLD worsens. Well, the management of NAFLD should obviously be holistic. The metabolic comorbidities like hypertension, diabetes has to be adequately controlled, as is obviously important in CKD also. Statins, if indicated, are safe, even in the face of elevated transaminases. Weight reduction is obviously the key our usual goal is to attain a weight reduction of 7 to 10%, and that is with exercise and with diet. However, bariatric surgery, endoscopic therapies can also be used for controlling the body weight if they cannot be maintained by lifestyle interventions alone, and if they meet the criteria for doing the same. In the sense that bariatric surgery is not indicated for the treatment of NAFLD per se. However, in patients who have undergone bariatric surgery, we have seen that the NAFLD, all parameters of NAFLD actually do improve. And the role of pharmacotherapy is actually limited. According to guidelines, it should be restricted to biopsy-proven patients. But in practice, we do not usually do the biopsy. Vitamin E and pioglitazone have been recommended by various international societies, although they are not approved for the same. Saroglitazar, this is a dual PPAR agonist, which has been recently approved by the Drug Controller General of India for the use in patients with NAFLD with diabetic dyslipidemia, NAFLD with F1 to F3 fibrosis, and in the presence of NASH. So this is important. I'll discuss some of the caveats in advising and interpreting the liver functions and related investigations. So when it comes to the AST and ALT, most labs report the upper limit as 40. AASLD has already recommended that with respect to hepatitis B, we should consider the upper limit of normal of ALT as 35 in males and 25 in females. We also have data from our country which have suggested that the upper limit of normal of ALT needs to be decreased. For instance, in a large study of male blood donors from our institute, we found that the upper limit of normal should be around 34. In dialysis dependent patients and even in dialysis non-dependent CKD, the AST and ALT concentrations are usually low, pretty low. And why is this? We exactly don't know, but it could be due to pyridoxine deficiency because pyridoxal phosphate is required for the production of these liver enzymes, or it may be that there is some inhibitory substance present in the uremic milieu. Given the fact that AST and ALT concentrations in CKD patients are actually on the lower side, a high index of suspicion should be used. And in fact, some experts have recommended these cutoffs for the of AST and ALT as the upper limit of normal. However, this is based on very early studies and not again widely practiced. Alkaline phosphatase levels may be elevated due to renal osteodystrophy. So therefore, before attributing a rise in alkaline phosphatase to cholestasis, a GGT, we should remember that it may be due to renal osteodystrophy. And in these circumstances, a GGT level may help to corroborate that the alkaline phosphatase is indeed of liver origin. Serum albumin, which we often take as a marker and indeed of prognosticator also in cirrhosis. Serum albumin levels may be low simply because of renal loss. Many of these patients, particularly the end-stage renal disease patients, may have ascites. And in that sense, there may be a confusion as to whether the ascites is due to cirrhosis-related portal hypertension or is it a nephrogenic ascites. If it's a nephrogenic ascites, the serum ascites albumin gradient or the SAG will be less than 1.1, whereas for portal hypertensive ascites, it will be more than equal to 1.1. Now, in our hepatology practice, we often use non-invasive scores like APRI or FIB-4. So even in end-stage renal disease population, even though we are commonly using these scores, particularly to rule out advanced liver disease, we should remember that APRI and FIB-4 are not validated in CKD patients. And this is particularly relevant given the fact that normal AST and ALT concentrations in CKD patients may actually be lower than what we observe in the general population. Now, in hepatology, we are very commonly now using elastographic techniques like FibroScan or RFE or ElastPQ to assess the underlying severity of fibrosis. Now, when we do this elastography, we are basically looking at the liver stiffness and using the liver stiffness measurement or LSM as a surrogate of the underlying fibrosis. In end-stage renal disease patients, because of the fluid accumulation, the liver will be congested and the liver stiffness values can be falsely high. Therefore, measuring the liver stiffness, performing the elastography after dialysis can help us to obtain a more real picture. So again, this is one study from our institute, and here we see that after the post-dialysis liver stiffness measurement values are far lower than the pre-dialysis liver stiffness measurement values. And in around 40 patients who had biopsy specimens available, the auroch for detecting significant fibrosis was much higher for a post-dialysis fibroscan, as represented by the green line over here at 0.74 as compared to pre-dialysis fibroscan, which had an auroch of only around 0.6. Therefore, elastography, whether it be by fibroscan, RFE, ELASP, etc., it should all be done after the performance of dialysis. The last and another vexing issue in many of the patients who are being considered for renal transplant and they have some evidence of liver disease is that we have to give them a clearance for renal transplant. And therein arises the question is that should we go for renal transplant alone or do we need to go for a simultaneous liver kidney transplant? For this purpose, we can actually divide chronic liver disease into these three entities. So chronic liver disease by definition is any liver disease that has lasted for more than 6 months. Now, either the patient can have liver is non-cirrhotic, or he may have compensated cirrhosis, or he may be decompensated cirrhosis. Ascites is there, upper GI bleed is there. Obviously, encephalopathy is going to be difficult to differentiate whether it is uremic or hepatic. So decompensated cirrhosis basically means ascites or portal hypertensive ascites or a variceal bleed. If the patient is non-cirrhotic, then there is no confusion. We can give a clearance for renal transplant alone under usual risk. If the patient has decompensated cirrhosis, again, there is no confusion. There is no question of a renal transplant alone, and the patients must be taken up for a simultaneous liver kidney transplant. The main confusion is in patients with compensated cirrhosis. Compensated cirrhosis per se is not a contraindication for renal transplant alone. And in these patients, we need to see what is the degree of the underlying portal hypertension. So if there is no CSPH, CSPH means clinically significant portal hypertension. So by definition, portal hypertension is a hepatic venous pressure gradient above 5 millimeters of mercury. And clinically significant portal hypertension is a hepatic venous pressure gradient above 10 millimeters of mercury. So if the patient does not have clinically significant portal hypertension, then we can go ahead with renal transplant. However, if the patient has clinically significant portal hypertension, then we need to go for a simultaneous liver kidney transplant. So how do we assess? Old guidelines actually only used to base all the decisions on the basis of biopsy. But now, since we have got good non-invasive tests, this is the algorithm that we are following at our institute. So when we have an ESRD patient with CLD, we first see whether we can reliably rule out cirrhosis or not. How can we reliably rule out cirrhosis? If the LSM is normal. Remember, a elevated LSM may be falsely elevated. So a high LSM does not tell us definitely that the patient has cirrhosis. However, a normal liver stiffness measurement on fibroscan or RFE rules out cirrhosis with a very high degree of certainty. Along with that, if the APRI and FIB4 are also normal, the ultrasound is showing normal liver outline, there is no splenomegaly, there is no ascites, all these criteria are getting fulfilled, and we feel that cirrhosis has been reliably ruled out, then we directly proceed with renal transplant alone. However, there is some doubt that no, we cannot reliably rule out cirrhosis, or if cirrhosis is present, then we see that is clinically significant portal hypertension present or not. Non-invasively, on the short of HVPG and biopsy assessment, we can do that by looking at the endoscopy. So if on upper GI endoscopy you have esophageal varices, then clinically significant portal hypertension is definitely present. Again, if the patient has ascites and the ascitic fluid is high sac, then again that is definitive evidence of portal hypertension. However, if the patient does not have varices on endoscopy, patient does not have ascites, or he has ascites and the ascites are low sag ascites, in that case, we go ahead with a liver biopsy by the transjugular route along with an HVPG assessment. This is very important. A biopsy alone will not be sufficient. We have to assess the hepatic venous pressure gradient also, because the biopsy will just tell us whether cirrhosis is present or not. The HVPG, if it is less than 10 millimeters of mercury, that will tell us the patient does not have clinically significant portal hypertension, and therefore he can be taken up for a renal transplant alone. Whereas if the HVPG is more than 10 millimeters of mercury, that means that the patient has clinically significant portal hypertension, and therefore he needs to be taken up for a simultaneous liver kidney transplant. Therefore, before I end, let's just come back to our case vignette. So therefore, our patient, he had his platelet counts were normal, AST and ALT were significantly elevated, albumin was normal. He had ascites, but it was a low sag ascites. LSM, which was repeated using fibroscan followed by RFE on 2 occasions, and in both the occasions, it was of it came in a cirrhotic range. However, the upper GI endoscopy, there was no varices. Therefore, since we could not definitively rule out cirrhosis because the LSM was high, so cirrhosis could neither be ruled. It seemed as if cirrhosis is possibly absent, but we could not definitively rule out cirrhosis. Therefore, we went ahead with a TGLB and a HBPG assessment, and the liver biopsy was suggestive of cirrhosis, but the hepatic venous pressure gradient was only 6 millimeters of mercury, so he did not have any evidence of clinically significant portal hypertension. Therefore, we took the decision to go ahead with renal transplant alone, and the patient continues to do well after 13 months of follow-up. And with respect to the hepatitis C, he had been treated with Sofosbuvir plus Velpatasvir and had attained sustained virologic response. So that's it. Thank you.